the ex-professor and Dean, Faculty of Medicine for BSMMU, Dhaka. And we are blessed to have Dr. A.K. Das with us, who is like done MBBS, MD, PhD, TMB, FMS, and he is a professor of medicine and head of endocrinology, Pondicherry Institute of Medical Sciences, and former dean and MS for the Jawaharlal Nehru Institute of PGMI, Pondicherry. And very shortly, I think, we will be joined with Professor AHMTA Chaudhary also, who is a chief consultant and known as the father of gynecology. He is a chief consultant at IMC, the past president of OBSG, and the past president of SAFOG, and currently he is working as a president for the Fertility Society of Bangladesh. He is an MBBS, FRCP, FRCOG, FCPS from Bangladesh in Pakistan. Both. So welcome you all panelists, and I really welcome all the doctors who have taken the time out there to listen the respected fraternity out there. So welcome you all. So once again, I would request, like I will take 2 minutes from all of you. A small message from our managing director. I would just like to share my screen. So kindly permit me out there. And we will like for the record keeping and for better understanding, I would like to take the permission from you all to record this session also. So may I go ahead, sir? Can I share this? Yes. Going on. Yeah. Thank you, sir.
I request all to mute.
Yeah, yes, kindly, all the participants, please keep your mic on mute. So it's a small message from our managing director.
Good evening. It's my pleasure to welcome all of you to this scientific seminar on current challenges in the management of hypothyroidism, and especially from a Bangladesh perspective, and also clinical decision making on thyroid hormone replacement therapy. A very, very warm welcome to all the doctors and delegates who have been able to make it to this scientific seminar. Merck is very proud to be associated with this program. Because all of you know, Merck has a very rich tradition and history, the oldest pharmaceutical company in the world, and is an innovator. Bangladesh in our presence and bringing our global innovation and molecules to the country, including treatments to treat hypothyroidism and other ailments in the cardiometabolic and endocrinology space. So this is just a first, but it's of a first amongst many innovations that we do plan to bring into the much more time of yours, and I would like to wish all of you a great conference and some very good discussions. Thank you very much.
So it's a small message from our managing director, and since the theory of the company is that really working as one for the patients, and our motto is to help out the patients of Bangladesh to do well and to do more. And to emphasize on this message, this is a small video which shows that how the curious is
life. A moment of joy comes from all pure love. A tiny breakthrough, or maybe a triumph, a constant struggle, ideas. Make a difference. Make the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning. Are we curious enough? Could we be closer? Can we? Can you feel it?
So, a small introduction to the Merck. Sir, Merck is there in the industry from almost 350 years by servicing the humankind. And we are not only in healthcare, we are into the different businesses also, like life sciences and the devices also. So, with this, I would like to hand over the session to Dr. Farooq Pathan to take it further, sir. Dr. Farooq.
Good evening to everybody. Thank you, Mr. Mukul, for conducting the session today. The organized program of the hypothyroidism as a whole, organized by Marx India and Jonathan Traders together. Indeed, it is a great pleasure for me as you had invited me to a chairperson and a speaker as well this meeting, along with Professor Das, one of my favorite faculty and friends. It is my great honor to get them, and along with we have the two eminent panelists, Professor A.K. Abdullah and Professor P. Chaudhary with us. They have great contribution in Bangladesh about the medicine and the gynae obstetrics in the context of Bangladesh perspective. And all the panelists and all the participants for entering the today's program. It is a great pleasure for me. The Marx has like to introduce the drug thyroid, though it is a very old drug in the field of hypothyroidism as a levothyroxine in the market, because it is a I think so more than 100 years of the introduction of this levothyroxine in this subcontinent. So it is also they intended to bring the drug in Bangladesh also. I think it's one of the innovative product they have, and one of the high quality product we can get, and it will also help our people who are suffering from hypothyroidism in different aspect. Today, with this few notes, I like to start the scientific part of today's program. First of all, I like to speak some of the important issue, the challenge of the hypothyroidism in Bangladesh perspective. Probably you see my slides. It is visible. So I like to start with my some small presentation with giving the glimpse of the scenario of hypothyroidism in Bangladesh and what are the challenges we are facing in this area about the hypothyroidism Bangladesh perspective.
Slide not visible. I cannot see the slide.
You can see the slides?
No, I cannot see.
So slides are not available here.
Okay, let me go.
Okay, if not available, you can continue.
Okay, no problem. Probably we can show. I think now it is visible. Now it is visible.
Oh, now yes.
Okay.
And
so this is one of the slides what we taken. We have to have one program 2 years back with the people, the reporters in UT in Bangladesh, and where I also participated in the program, and where I said that probably 20 to 30% people of Bangladesh are suffering from any type of some sorts of thyroid disorder. As we have no evidences in our country, data in our country, but from the country, our neighboring country India, but we have seen the same scenario also. Probably we expect in Bangladesh also. Nearly 30 million people total, even does not aware the condition, though 50 million we are expecting the people suffering from thyroid disease, and half of the people do not know what they have in their. There is awareness program in Bangladesh about the people, among the people, also among the physicians also, and it is more common in females and in the males that we are expecting, and it is also more worse in rural areas as there is no such a physician in that area. They are not aware about the condition, and there's no facilities to detect the thyroid problem either by ultrasound or the biochemical test and as a whole. So it is a silent clear the disease in Bangladesh. Probably if we see the prevalence study, though we have no such prevalence study in Bangladesh clear cut, that's some sporadic study I have done before. From that I can say if you compare with the diabetes prevalence in Bangladesh, probably it is thyroid disorder prevalence is more higher than the diabetes diseases. At least at this moment, we say that 80 lakh people are suffering from diabetes. But I think so the prevalence of the total people population suffering from thyroid disorder is far higher than the diabetes population. So you can understand it is a underdiagnosed, undernoticed most of the time, and the people suffer for a long time and have the different set of consequences as a whole. This is one of the studies done published in 2008, where it is said that though iron deficiency disorder in Bangladesh is found to be higher before the 1993 when the study was done, where you've seen the iron deficiency was found to be 70% in the children and 70% in the women in 1993. After iodization program, mass iodization program in Bangladesh, which started 1993, and the survey done again after 10 years, about 2004 and 2005, it is found that the drastic reduction of the iodine deficiency is found in Bangladesh. It is found in 38% in children and 30% in the women. And this is one of the great achievement probably in Bangladesh about the mass iodization program and instituted 10 to 15 years back. So this is one of the important issue how we can get the less prevalence of the goiter in particularly in the northern part of the country. Even then the scenario is not still exist, and hopefully in near future we can have total mass population, we can go under the universal salt iodization program, and it will definitely reduce our the problem either in the goiter, thyroid goiter or hypothyroid or in form of thyroid disorder in Bangladesh. It is another study. These are probably one of the study in the community basis because it is important for us. It was done in the southern part of the country near the Khulna area, 2006, where they found that overall occurrence of thyroid disease estimated about 20%. Probably the scenario has changed a lot. I think so. My expectation is that the overall occurrence of thyroid disease is going high day by day. Exact person do not know about it, and I found that in their study, the female hypochondritis about female about 2.5%. Also, the hypothyroid we can get about 5% at that time, and the clinical hypothyroid about 6% total, 10% of people what is this, and some also who can get the hypothyroidism and subclinical hypothyroidism. And goiter also found to be there, and they have also found that incidence of autoimmune disease, thyroid disease, is about 8%. Even though you can get the non-goiters thyroid, we can get also the thyroid antibody positive also. So that is one of the landmark study in Bangladesh. Though this is the population is the less, but it's one of the importance. There is another study done among the finding of the hypothyroidism in his lipid because the lipid profile is also get to rearrange in hypothyroidism. Among the different patients, they found that nearly 11% is suffering from lipidemia just found to be hypothyroid, which is found to be about 10% hypothyroid. When you see that hyperlipidemia, if you can screen the patient with the that are suffering from probably this indicator will not be between the anticipated dark cause and ultimately succumb to the cardiac artery disease and cerebrovascular disease. Another study, a community-based study in the rural areas, it found that irrespective of the sex, irrespective of the occupation and age, that it is found to be about 7% of population suffering from the thyroidism. And there is no association is found hyperglycemia, obesity, the increase in age or obesity or blood pressure, lipid, but it is found that in that study that there is a association with hypoglycemia is a significant risk of hypothyroidism in that study. Another study done prevalence of thyroid dysfunction and thyroid autoimmunity in polycystic multi-center study done. It is found that also the patient suffering from PCOS, but they have found the dysfunction of thyroid autoimmunity. There's another studies also done in the PCOS cases, and at least in my study I've seen about 30% patients, children or PCOS also have hypothyroidism along with the hyperprolactinemia. Hypothyroidism also in type 2 diabetic patient attending type. Also, this is another study done by Afzal. It's found that hyperglycemia is a significant risk of hypothyroidism, and the subclinical hypothyroidism frequently found in the female elderly people and subgroup of IBMR in the people suffering from the diabetes. The routine screening of their function tests should be done. Also another challenge for us to share that make awareness among the physician. If the patient is found to have hyperglycemia or depression, it must also screen for the wider suffering hypothyroidism. In another study is done in we've seen that lots of pregnant lady also have found to be suffering from subclinical hypothyroidism or hypothyroidism, and leads to the pregnancy loss. It is a frequent finding. In this study, they found that prevalence of thyroid disorder did nearly 30 to 40%, and incidence about 20%. So the hypothyroidism is a great challenge in Bangladesh because the symptoms are very much mild and subtle, and most of the sometimes symptoms are non-specific and signs also non-specific. And nearly 50% found to be asymptomatic and subacute condition. And ultimately, if not they are assessed properly, they go to the end organ effect. And ultimately, they have the overall rate of edema we can use in some patients. So that because of the increasing awareness among the physician, and we are getting less edema patients in our current scenario. And the presentation is heterogeneous, and because of the presentation is with different age and the along with the age and the illness. That's why the presentation in infants one type, and then in pregnancy another way, and in gestation another way, elderly also another way. So if the person is suffering from different comorbid condition, also that we can mask of the clinical features of the signs symptoms of hypothyroidism. And because sometimes the changes occur in the critical illness patient and non-critical illness patient, there's a loss of physiological change and the thyroid dysfunction. We can also found the hypothyroidism either in the form of subclinical or apart in the form. So the heterogeneity, not only the in the presentation, that also the heterogeneity also occur to take the decision what the target level or thyroid level we can make in patient, either the children or elder age or in the pregnancy cases. So there's a lots of heterogeneity exists in the diagnosis. At that point, also that heterogeneity exists in the treatment and target thyroid level in different age group and different conditions. Patients suffering when they present with the hypothyroid conditions. And the changes that the thyroid gland has sometimes we have normal where the count to be normal, FT4 also count to be normal. In hyperthyroidism, as you know, that T cell level is going suppressed from the pituitary, and the FT4 is high because of the high suppression of the pituitary gland and low TSH. And the hypothyroid are two types, and primary and secondary. And hypothyroid is primary, we can get the disease of the defect in the thyroid synthesis for practice, and TSH level found to be high, FT4 level is low. On the other hand, secondary is another very important challenge for us to get a diagnosis of the hypothyroidism that is secondary from pituitary origin, why we can get the low TSH and low FT4, which is difficult position. The clinical scenario and clinical eye is guide you how that person is suffering from subclinical and the hypothyroidism, secondary hypothyroidism, along with the other anti-pituitary deficiency. And lots of patients we can get now where the TSH level found to be high for FT4. Level is normal, but
Assalamualaikum.
subclinical
जी भाई अस्सलाम वालेकुम
and the cut point of the subclinical
जी
hyperthyroidism
अस्सलाम वालेकुम
is difficult. Either the TSH level is
जी अस्सलाम वालेकुम
let's say 7 or 18 15 milliunit. So the cut point also differ from different the guidelines and different consensus guidelines, the different and the scientists. Still, it is a dilemma. What should be the cut point of the subclinical hyperthyroid about the TSH level? So it is important for whether you would like to go for treatment or not to go for treatment. So steroid the subclinical hyperthyroidism, one of the late issue controversies. There are lots of pros and cons of it. Whether we are who are the candidate to be treated. So it's to not treated if we consider some are benefit as there, particularly those who are under the age of 70 or women who are pregnancy or in the infertile or if some symptomatic goiter is there to reduce the goiter size and symptom, or you had those who are also get benefit if the anti-APTS positive is found to be subclinical hyperthyroidism, or person who are high risk of study. On the other hand, there is a lots of risk also found if we treat as subclinical hyperthyroid, the cardiovascular events like tachycardia, atrial fibrillation, even the worsening of the heart failure, angina may occur. The patient is the masking of the disease, and fracture is also increased if we overtreat the patient. The patient already have the fracture risk is there, and we treat the patient subclinical hyperthyroid with our treatment, all may worsening the osteoporosis and fracture risk. And so some untreated psychological conditions also are one of the important issue. And severe anemia patient, if you go very slowly, it is found to be headache, worsening of the heart failure may be occur in severe anemia. So either you treat the subclinical hyperthyroid severe anemia, if we found that is the only cause is subclinical hyperthyroidism leading to anemia because of the synthesis of the thyroid hormone is important, the synthesis of the disease also, hemoglobin also. So that's why that is one of the great issue in our hand of whether subclinical hyperthyroid should be treated or not to be treated. There's some benefit is there, some risk also there. We have to our balance between the two, whether you like to treat subclinical hyperthyroidism. Hypothyroidism also is a great challenge for us in the elderly people because diagnosis and management is quite difficult because of the less symptomatic than the younger people. And if you see that during the age going up, the cut point of TSH levels is going up. So what is the cut point of the age of 65 or 70 or 90 years is also get changes because of this physiological change of occur as the age is going up. The functions also found to be deranged, so that the cut point of TSH levels go up to make a balance the hemostasis mechanism status in the people, particularly people. So this is cut point is also as the age is higher, the TSH level we physiologically TSH level is normal to this continue physiological normal TSH levels found to be high. So difference in clinical presentation also differ in the older people, and the presence of the non-thyroid illness is there, which might obscure the features of the thyroid dysfunction. And the older people are getting lots of medication because of the different condition. That might also important issue while you like to treat hypothyroid in the elderly people. And it is several consensus is there whether you treat the older people with clinical hypothyroidism or not. And according to this, the consensus is that if the patient is fit, older people is fit or a frail patient. So if the age is less than 75, if the TSS level is more than 10, you can treat the patient. If the age is more than 75, even the TSS level is more than 10, you can treat or you can observe the patient is going to the thyroidism. If the frail patient, if the age is less than 75, just observe, and if you feel the benefit can done for the patients, then you can treat the patient and very slowly with the cut point of THS level, making the higher level in the usually younger patient level. What you keep usually the two or three THS level are higher. The elder people may keep the patient around 6 or 7, so that you do not have any insult of the cardiac status. If the field patient is more than 75, just observe the patient and see how that patient is going to about hypothyroidism or not. So this is one of the strategies we can take in the older people while whether we can treat the clinical hypothyroidism. It also get importance that hypothyroidism in pregnancy population. More from the course I could ask about it. That there's a lots of physiological changes occur during pregnancy period, which mask the symptoms of hypothyroidism during pregnancy period. And one of the most important issues that heart function test is not easily routinely done. And I think so. They can also during the counseling of the pregnancy counseling, planned pregnancy counseling. Because of in our region, we have no planned pregnancy counseling, but pregnancy is the screening program. So I think so. This should be done. If any couple like to have get pregnancy, they should intended to do pregnancy. They should have their routine thyroid function test whether they are suffering from hyperthyroidism. If they are suffering from hyperthyroidism and is untreated, probably they will after concept. They do not usually concept. If they concept, they succumb to the either calling abortion or miscarriage. This is one of the important issue. So adverse of physical outcome and long-term development equally also come. It is one of the important item we can think while dealing with the hypothyroidism pregnancy. Subclinical hypothyroidism, we have already said that in the diabetic patient, or even on our slide, we have seen that subclinical hypothyroidism also pretty much prevalent in the diabetic patient because of the insulin resistance is there. And over the subclinical hypothyroidism is associated insulin resistance. And there is a physiological requirement of insulin also found to be diminished in hypothyroidism. And metformin also lower the TSS level sometimes mask the problem. And subclinical hypothyroidism increase the risk of obesity, worsening of the nephropathy, even the cardiovascular events in patients who are suffering from diabetes patient. So in diabetic patient, whether we like to treat the patient or not to treat the patient is one of the important challenges, while particularly in the subclinical hypothyroidism. And there is a good relation association in the hypothyroidism with the heart disease, hypothyroidism related. Urticaria marks the asymptomatic coronary disease, and thyroid hormone deficiency worsening the prognosis of the coronary disease. Either it is acute or it is chronic. And one of the important issues that immediate reduce the thyroid hormone iron overload. This is also another issue. If we think a patient is getting amyloid, follow the patient, or the patient is the thyroid dysfunction, particularly hypothyroidism, occur or not. So in a patient who are taking the imidazole in a cardiac faculties, they should screen for the hypothyroidism, whether patient is getting hypothyroidism or not. So central hypothyroidism another challenge for us because while I would like to treat the patient with a levothyroxine replacement, residual the THS secretion is going to be suppressed, and not only that when the patient is antipituitary deficiency, hypothyroidism, there are lots of other deficiencies there that make the situation of the replacements also complicated in that moment. And there is no single optimal levothyroxine. Those what is the target of the treating of the hypothyroidism? when hypothyroidism, the patient is having the hypothyroidism, when hypothyroidism. At that moment, what is the target? Do we think the target level should be with the PSS level or the FT4 level? If the FT4 level, we have to target it to have the optimal replacement of the levothyroxine. What should be the level of the FT4? Either is the upper level, 50% the upper level or not. This is another issue, is a challenge for us. How we try to replace the levothyroxine in the and the secondary hypothyroidism, particularly when hypothyroidism. Is another issue on the hypothyroidism in our country because there is no universal screening of infants. Still, we were lacking the consensus about the universal screening. All infants, all the neonates just born to have the universal screening because particularly it is important for the preterm and the low birth weight. If we miss the diagnosis, probably we can get the delay in the growth and development, and particularly the brain development issue is important issue. For that reason, I think so. This consensus should be raised in this area also in the subcontinent. The universal screening of the neonates also important. Universal screening for the hypothyroidism for the pregnancy or plan for pregnancy also important issue in our, and most of the time because of the lack of awareness, lack of knowledge about the physician, the diagnosis most of the time is going to be delayed. Sick day management, the person is suffering from hypothyroidism has sick days about the critical illness. There's also lots of changes are occur, the physiological changes occur in thyroid function about the level of the THS, level of the people after the FT3, and lots of the drugs patient is taking, and which may impair the absorption or action of the levothyroxine. And most of the time, while the patient is suffering from acute illness, they usually stop the drug on the levothyroxine many of the time. Even that the subjective people who are doing the surgery, patient is getting the thyroid replacement, they stop the drug for the time being of the 4 days. It should not be there. So their lack of awareness is also important here. We have to raise the issue during the surgery of the acute illness. The drug should not be stopped at all. And no establishment guideline is there during the hypothyroidism, management hypothyroidism, due to illness still is lacking. So with this, the points of what I already stated about the evidences of what we have in our country, though the evidence and data are very much few, still our people, the doctors and consultants are doing the studies about the thyroid disorder in Bangladesh, either community level or the tertiary care level. There's sporadic in case of diabetes, in case of PCOS, in pregnancy, in case of children pediatrics. People are doing that. Still, the data is not enough to say anything for that. Still, my question is that here, in spite of the adequate iodination program in Bangladesh, thyroid disorder is increasing. This is one of the important issues. Whether this genetic link is there, or that is undetermined environmental factor like the kind chemical say is there, either solution is there. What is the cause? Still, it is this is we are in the dilemma, and whether we have to there is the issue about the why that the increasing prevalence of thyroid disorder in Southeast Asia, particularly Bangladesh, is going up. Whether there's a link, genetic links is there, whether it is undetermined environmental factors there, we have to find out the cause. Probably if we do that, we can address and we can make a consensus statement and the guidelines to with the issue of hitting hypothyroidism or subclinic hypothyroidism in the people who are suffering from them. Thank you for that. With this note, I like to conclude my presentation about the challenge of what we are facing by our endocrinologists, our internalists about the thyroid disorder in Bangladesh. And hopefully we can get more information from Professor Kedas for his presentation. Here I like to, my privilege to introduce, I feel get honor to introduce Professor Kedas. I already said he's our old friends. We have lots of program in our abroad and in our country also with Professor Kedas. He is a presently professor of medicine and the professor of head of endocrinology, Pondicherry Institute Medical Science. He was the former senior professor of medicine and endocrine, head of the department of endocrinology and dean medical superintendent of the Jawaharlal Institute of Postgraduate Medical Education and Research, Pondicherry. He has lots of contribution in the field of endocrinology and medicine. He is a member of Physicians Research Foundation of Association of Physicians of India. He is appointed chair of the various national programs like Integrated Disease Surveillance Program, IDSP, National Program of Prevention and Control of Diabetes, and CBD and Stroke, Scientific Advisory Group, SAG of ICMR on non-communicable disease program, ICMR Task Force on Diabetes in the Young, Mapping Diabetes in India, and India Diet Study, ICMR, the becomes a mega study in the dietary study in India, WHO Promoting Center and CDs with Mohans, and he developed many guidelines on diabetes through the Association of the Physicians, Indian Council of Medical Research. He is also the national president of the vice president of various national associations of diabetes and Food Society of India, Diabetes and Pregnancy Study Group, Deep Sea and Research Society of Study, Diabetes India, RIST, Association of Physicians of India, IAPI, and India College of Physicians. He is a recipient of the lots of the achievements of lifetime achievements like the Jibraj Mehta Award by the Association of Physicians of India. He has various contributions of the field and the research also. He has lots of publications and to his credit published in international and international journals, in addition to the books, chapter and books also. And with this few kind introduction of Professor Kedas, one of the favorite physician and researcher, I'd like to invite Professor Kedas to start his deliberation and enlighten us about the thyroid disorder as a whole in different aspects.
Thank you, sir. My sincere regards, love and greetings to my very dear friend, our president of this meeting and the president of the society in Bangladesh, Professor Farooq Pathanji. My greetings to all my friends who have joined and to my co-panelists, Professor Abdullah, Professor Chaudhary, and I bring the greetings from India to all the people of this country who are very near and very dear to me and close to all of us. Dear friends, I was just now telling Professor Pathan that coming here is a pretext, but the main objective is to meet each other, to exchange ideas and take the practice of diabetes endocrinology in this part of the country to a higher pedestal. And dear friends, Professor Pathan's very, very masterly scholarly lecture on the aspects of hypothyroidism in Bangladesh has opened up newer vistas in front of me. He has touched upon many areas, but I'll be touching upon few of them, trying to answer the questions that he has made. I'll just say that the environment possibly is the factor which makes the hypothyroidism strive. I have corrected 2 dissertations from Kerala, which shows the contamination of the soil and the things there. We will discuss that. I fully agree with him. There are 2 diseases which you cannot diagnose unless you keep it in mind, and one of them is hypothyroidism. And you know, in internist we teach you cannot diagnose multiple myeloma unless you think in mind that aches and pains can be because of that. Similarly, hypothyroidism is a great you cannot diagnose unless you keep in mind. Dear friends, I start now sharing my slides, and can I share my slides? 1 minute. I'll just move it. 1 minute. Yeah, dear friends, this was the fact which was unveiled on the April this year on the World Thyroid Day. It said where Bangladesh stands as regards hypothyroidism. Dear friends, I'm extremely thankful to Merck for having brought me to this virtual meeting and to participate in the launch of a great molecule, euthyrox, the levothyroxine from the Merck, which is available in 113 countries and it has been also called the molecule of the decade, and we'll discuss about it. But I'm extremely thankful that they have facilitated my meeting with my friends like Dr. Farooq, Dr. Abdullah, Dr. Chaudhary, Dr. Farina, Dr. Indrajit, and all the names. I mean, so many of you have joined. My joy now bounds, and give my greetings and pranams to you all. Dear friends, on the World Thyroid Day in 2021 in Bangladesh, we wanted to find out Bangladesh, the state of the nation called Bangladesh on as regards thyroid is concerned. Dear friends, I have taken 3 sentences. Number 1, thyroid is the most important contemporary challenge. That's what Dr. Pathan said in every sentence. It's a current disease. And number 2, it is a silent epidemic. 60%, I'll repeat again, 60% of the thyroid diseases remain undiagnosed, and most of them are hypothyroidism, for which the treatment is available beyond description. I just tell you a story. I told you that I'm in a mood of talking to you today. There are Americans, the story of 2 American presidents. One American president died of tuberculosis because that time anti-TB drugs were not available. But another president of America died because of hypertension. And if I remember, Dr. Abdullah, Dr. Farooq Pathan, and Dr. Chaudhary remembered, there was a debate going on between the 2 great hypertensiologists, whether treated or not treated. He was not treated of hypertension, and he died of hemorrhage. So the moral of the story that we have very, very effective treatment for hypothyroidism available today. Therefore, screening is a must. I'll repeat again, access to screening and early screening, I'll show my slide, is a must, because 60% are not diagnosed, are silent. Now in India, we have about, in globally, we have about 200 million people, and out of them, 50% in Bangladesh, 60%, India, 62% are not diagnosed. Number 2, with the universal iodinase of the salt, both the countries, my country and your country, has changed the scenario of the hypothyroidism in the newborn. The cretinism is almost out. Between 1993 2007, it happened in Bangladesh, and that has changed the scenario. It has been a game changer. Third, the actual burden of thyroid dysfunction, I won't say largely unknown. After listening to the masterly presentation by Dr. Pathan, in the dyslipidemic patients, in pregnancy 35%, in the dyslipidemic patient starting between 9.5 and 2.5% overt and subclinical. So the statistics in Bangladesh is superb. I congratulate you that you have the statistics. But to make a long story short, we can say that roughly both in India and Bangladesh, 20% of our general population is suffering from the thyroid disorder. Dear friends, thyroid hormone is the most important hormone. Why? Because it plays important role in the brain, in the nervous system, in the psyche, in the growth and development, in the energy metabolism. Thyroid hormone makes a man leader, and on the oxygen consumption, it gives to maximum muscle function. It takes part in the protein, lipid, and carb metabolism. It has an important role to play in the cardiovascular system, in the bone metabolism, and Professor Chaudhary is here. It is the hormone for the fertility and pregnancy beyond the reproductive hormones. So that is very important. Dear friends, I must also tell you that there are 5 common thyroid diseases like hypothyroidism, hyperthyroidism. There can be goiter and iodine deficit disorders, Hashimoto's thyroiditis, which has in the beginning toxicosis, passes on to hypothyroidism and the thyroid cancer. So this is exactly the 5 common diseases that we have in the spectrum of thyroid disease. Now I'll tell next 3 slides outlining what are the causes of hypothyroidism, which is the focus today. Number 1, autoimmune. Autoimmune thyroid atrophy, the atrophic thyroiditis, the thyroprivic hypothyroidism, no goiter hypothyroidism, which is the most important disorder, is number 1. Autoimmune lymphocytic thyroiditis, which is possibly Hashimoto's and non-Hashimoto's, and there is usually a history of autoimmune disease in the family, like one can have vitiligo, one can have specific other autoimmune biomarker, or it can be number 2, post-ablative or following surgery or radioactive iodine treatment. It can be transient. We find transient hypothyroidism, my dear friends, in the subacute thyroiditis, which is called silent thyroiditis, postpartum thyroiditis, and in the early therapy, radiotherapy, called early post-ablative radiotherapy. Now, it can be because of viral infection, pregnancy, radioiodine ablation, and this is called subacute thyroiditis, which gives transient hypothyroidism. It can be also hyper to start with. And of course, iodine associated, mostly iodine deficiency, but of course, iodine increase in the diet can produce hypothyroidism. It can be because of various other diseases like infiltration. I mean, we have seen so many cases of tuberculous thyroiditis giving rise to hypothyroidism, hemochromatosis, the amyloidosis, scleroderma, and the reader's thyroiditis. And you can diagnose by personal history or systemic features. Dr. Patan alluded to neonatal and congenital. Now, this is because of thyroid agenesis or ectopic thyroid where it cannot grow. The genetic disorders affecting thyroid hormone synthesis, transplacental transmission of TSS receptor blocking antibody, which is a disease to reckon with. And rarely you can have secondary or hypothalamic pituitary diseases like thyroid hormone resistance syndrome. There can be autoimmune destruction of the pituitary. In this part of the country, India and Bangladesh, we have snake bite induced bleeding in the pituitary and in the pituitary hypothalamus axis, which can produce Sheehan's secondary hypothyroidism. And therefore, this is a huge disease in this part of the country. This is a very common slide. Please allow me 1 minute to dwell on it, because we have to remind ourselves that thyroid disease can have widespread effect. It can have it can have in the brain. It can produce depression, decreased concentration, feeling under the weather, general lack of interest, some amount of memory loss. It can produce bradycardia, increase in the blood pressure because of the viscous blood. It can produce decreased cardiac output, decreased renal function and fluid overload. It can produce in the reproductive system great things like decreased fertility, men's abnormalities, and may harm development of the infant. Constipation is a very important symptom and decreased GI activity. It can produce increase in the lipids, as just now we heard, increased LDL, cholesterol, elevated triglyceride, and have widespread effects. It can have poor memory and concentration. It can produce pleural effusion. We've seen so many cases. Most important is the hair loss, which is a universal problem today. Hypothyroidism is a very important feature of that. Delayed tendon reflexes, weight gain with poor appetite, carpal tunnel syndrome, shortness of breath, deafness, sensory neural deafness, hoarseness of voice. Most important, multiple aches and pains, and feeling under the weather, fatigue, feeling cold, and also the coldness of the extremities. Why I spent a minute just to emphasize that one has to keep a high index of suspicion when one encounters this, because this can be the very important symptoms of hypothyroidism. Dear friends, as already illustrated by Professor Pathan, I'll just make it a little more clear that we have division depending upon three things: time of onset, level of dysfunction, and the severity. It can be congenital or acquired. Congenital I alluded to, we'll come back to in the discussion. The level of dysfunction can be primary, that is in the causes in the thyroid, like Hashimoto's thyroiditis, surgery, ablation, infection, thyroid dysgenesis, deficiency, thyroid hormone biosynthesis, many syndromes starting with the ordinary syndrome to pendred syndrome. They do not get thyroid hormone properly synthesized. Or you have autoimmune ablative hypothyroid syndrome, or it can be secondary to tumor, trauma, and infections, or congenital deficiency, which is very rare. I mean, it can occur due to hypothalamic diseases, but extremely rare. But one must remember that hypothyroidism can be overt. You look at the person who diagnosed, but more often than not, I'll repeat, more often than not, one has to maintain a high index of suspicion to diagnose mild hypothyroidism, which is rampant, 60% and 25% population. I just want the paper to speak about how a snake bite induced hypothyroidism and secondary hypothyroidism was totally missed. It is not incompetence, but it is possibly ignorance. Now, it was a 42-year-old gentleman presented to OPD, a 10-year history of general weakness, lethargy, coarse facial features, reduced libido, reduced socialization and depression, had an acute illness following a snake bite 15 years back. And he had altered sensitivity of that failure that time. He required dialysis that snake bite time. So managed the general physician who diagnosed hypothyroidism correctly, but could not possibly diagnose that it is secondary to pituitary. Therefore, he was given levothyroxine, but did not improve till he was given the other hormone, which is necessary for the secondary hypothyroidism. He was given steroids. So it doesn't. So in India, in Kerala, in various parts of India, we have snake bite induced we have snake bite induced bleeding in the pituitary axis, which can produce exactly like what we get in Sheehan syndrome in the postpartum hemorrhage in the pituitary and pituitary apoplexy. So one has to keep the mind open to this particular entity in this part of the country. Now, I must also tell you that there's a postpartum syndrome called postpartum hypopituitarism, Sheehan syndrome, developed postpartum autoimmune thyroiditis. There can be beginning little bit of thyroid excess, but ultimately thyroid hypothyroidism. And there are plenty of description of this postpartum hypopituitarism in the literature. I will not go details of it. Now, how do you diagnose? I believe it is the simplest in the world, and the greatest truths are the simplest. What we need is thyrotropin, TSH. We need FT4. We may need FT3, and we need at times, it's better to do TPO antibody, thyroid peroxidase antibodies, because that gives a great answer. Now, I will drive home a point to the students present here that we are talking about free thyroxine, because in various conditions, say of pregnancy, TBG will be high. So total thyroxine will be high. It can go up to 16, 15. So that will vitiate the picture. We need free thyroxine and free thyroid, but most important is the TSH. Now, this is the slide on the screening. Dear friends, I am favor for the mandatory universal screening, but we wanted to introduce, we have adopted in 4 states in India, all newborn infants. In many countries, it is mandatory. India is not mandatory yet. We have only 4 states. In a Down syndrome, it's a must. In pregnancy, with or without a water, anybody who is pregnant, a thyroid TSH estimation, screening for the hypothyroidism is mandatory. It can change the scenario. A little effort, Dr. Chaudhary will agree with me, produce a great change and change the destiny of the patient, the mother and the child. So pregnant women, I'm very passionate, must have mandatory thyroid screening for the hypothyroidism. Strong family history of thyroid disease, personal history of thyroid dysfunction. People who have any other autoimmune disease, every type 1 diabetics, we discussed the other day, we must screen for hypothyroidism. We do that. People who are taking lithium for the manic depressive psychosis. So lithium can produce hypothyroidism. People who have depression. And of course, just though we heard the word lipid elevation, one of the important causes of lipid estimation. It is not diabetes alone. It is not nephrotic syndrome alone. It is not the familial dyslipidemia alone. One of the very important symptoms of lipid elevation that we find in our clinics is hypothyroidism, and one must look for it. And of course, somebody who has a thyroid nodule. Now, dear friends, we have this classification of the disease, very simple. Primary hypothyroidism, TSH is high, feedback mechanism, and T4 is low. If you have subclinical hypothyroidism, the TSH is high, but the T4 is normal. I'll just again emphasize, if you have TSH is high, but FT4 is normal, think of subclinical hypo, which Dr. Pathan emphasized so nicely. So think of subclinical hypo, and to make a long story short, I strongly believe they have to be treated. So which situation they have to be treated, and little more things will add to what Professor Pathan has said. Secondary hypothyroidism, you find the free T4 is low. At the same time, because the pituitary has failed, the TSH levels are low or normal. Now, in autoimmune thyroiditis, which is a very important entity, you find that TPO antibodies are high. We take 50 in our lab at the cutoff. And also anti-thyroglobulin antibody is also high. Therefore, the interpretation of the thyroid function test, I have brought a very simple chart for you. High TSH. You have low T4, primary hypo. You have normal T4, subclinical hypo. So very simple for the students to know. You have normal TSH, you have low T4, it is secondary hypo, or what we discussed, of course, Dr. Patan again alluded to it, a severe non-thyroidal illness, we call it sick euthyroid syndrome. I'll again, in spite of taking time, I will again emphasize high TSH, low T4, primary hypo, normal T4, subclinical hypo. Now, normal TSH, not high, but normal TSH, low T4 is secondary hypo or severe non-thyroid illness, what we call the sick euthyroid syndrome. Now, you know, this sick euthyroid syndrome is a very important clinical problem. We have not yet solved the issue whether it is because of adaptive changes or it is a disease by itself. We don't know how to treat it. To make a long story short, I must tell you that in the absence of thyroid disease, patients with non-thyroid illness like septicemia, like they have very severe kidney disease, heart disease, what happens? When you do thyroid hormone functions and measurements, we may find they have thyroid dysfunction, they have hypothyroidism, but these are adaptive changes. This is called sick, but euthyroid syndrome. The T4 may be low, FT4 you have to estimate, but is an adaptive syndrome. The degree of thyroid function impairment correlates with the disease severity. So sick euthyroid syndrome is an indicator of the severity of the disease. There is nothing simpler in the world than managing hypothyroidism, and all that it is hormone replacement therapy. So why you would give the therapy? To ameliorate these symptoms. I have told all these symptoms to normalizing the TSH secretion level, reduction the size of the goiter, and avoidance of overtreatment by not to produce iatrogenic thyrotoxicosis. Now, why do I prefer levothyroxine, which is euthyrox, which we big launched in this country today? Now, this hormone replacement therapy, levothyroxine, is the treatment of choice for routine management and for the low initial doses and gradual titration. Why we for levothyroxine will come in a minute. Now we have to monitor the treatment by estimating TSH and clinical biochemical evaluation 6 to 8 weeks later, and we have to monitor FT4, and if you want you can monitor FT3. I don't do it daily. Now this L-thyroxine, levothyroxine, is a synthetic T4 hormone. It has a long half-life of 7 hours, so works the whole day. And this is absorbed much more easier than the other compounds. And it is available in multiple tablet strength because we give multiple strength tablet to multiple patients. So it is available multiple strengths. And you know, addition of T3 does not give any other extra benefit. In the lay community, you find in the various other people, those who are not medical doctors, they give treatment to T3, but addition of T3 is doubtful to produce any other extra benefit. Now, so hypothyroidism requires treatment with levothyroxine. It is 80% absorbed from the intestine and predominantly in the upper intestine, and more so in the fasting state and late state. And it is better not to change the brand, any brand. It is also the advice by the Thyroid Society, the APA, same advice. Why? Because there is a difference in the bioavailability between different brands. Therefore, we do not want to change the brands. Now, serum T4 concentration usually peaks 2 to 4 hours after the oral dose. That's why given in the morning when maximum activity is needed. But it remains above normal for at least 6 hours. I told you 7 hours. The long half-life of thyroxine, about 7 days, allows treatment with a single daily tablet. And so this single daily tablet, we advise half an hour to 1 hour prior to breakfast. Because the half-life is 7 days, the level is maintained in the blood for the entire 24/7. Now, if you're giving any other medication, now we are getting another medication which will come to your country shortly, like something called Revelsys, which is an oral GLP-1 analog. That has to give an empty stomach also. But if you're giving any other drug, a minimum gap of 2 hours, not between food and the drug, if you're giving any other drug with the administration of thyroxine and the other drug, the gap must be about 4 hours. Dear friends, how do you monitor the treatment? Please excuse me for carrying cold to Newcastle. Assess the serum TSH and FT4 up to 2 months. If serum TSH is normal, continue the same dose. If the serum TSH either is elevated or suppressed, there will be need to a modest increase or decreasing the dose respectively. And usually at one go, we do not increase more than 12.5 to 25 microgram, and we measure TSH again after 2 months. Once patient has become euthyroid, we measure the TSH post that 6 months, and once a stable thyroxine dose is achieved, we need to check TSH only annually. So that is the protocol given by the Indian Thyroid Association, the ATA, and across the board. In the patients who have got hypothyroidism because of radioactive iodine ablation, there is a thyroid reserve which slowly comes down. Therefore, in them, we advise 6 monthly assessment because, we give radioactive iodine. That it does not take away the thyroid hormone within 3 months or 6 months. There's a continuous ablation. So therefore, we need semi-annually assessment of the TSH in such situations. Now, what is the clinical response? Very, very interesting. What things changes first? The earliest clinical response as given by in the literature and by the experts is little bit of diuresis and weight loss because of the mobilization of the fluid. Now, this weight loss consequent to decrease in the fat is very minimal, but the real weight loss manifests late in the disease. Many people today add T3 triiodothyronine. I mean, this is not medically correct. The people who are quacks, they add T3 to produce faster weight loss. I'll give a word of caution. It is of no use. Adding T3 does not produce faster weight loss. After weight loss, what other things improve is usually appetite, the constipation improves, the hoarseness of voice improves, and much later you get freedom from the cold intolerance and the fatigue. Now, why some people have poor compliance? They do not improve. The number one cause is common sense approach, where the compliance is poor. Now, when do you think there's a poor compliance? What are the clues to think that patient has a poor compliance? You suddenly find there's a high thyroxine requirement. Somebody is requiring about 75 or 100 or 120 per microgram. The requirement has gone up to 300. And you find that the T4 level is normal during treatment. I'm referring during treatment, the free FT4 is normal, but the TSS has become elevated. He's not compliant. He has taken T3 for a few days, but not taken regularly. And if you do serial thyroid function test, if you find erratic and inexplicable result, you can be certain it is probably not compliant. What are the adverse events of levothyroxine? Dear friend, again to make a long story short, nil. It has no side effect if the dose is correct. If somebody has overdosed, given too much of thyroxine, or you increase the dose very high, 100 microgram, 50 microgram in a single visit, you can find symptoms of hypothyroidism, common sense. And very rarely one can have hypersensitivity to one of the constituents of the component. What are the contraindications? Of course, hypersensitivity. If there is adrenal insufficiency and you have not treated that and you are giving thyroxine, it can produce adrenal crisis. Because once you give hormone, it calls for great hormone release to cope up with the increased thyroid hormone. But if adrenal is failing, say something of a Sheehan syndrome, the adrenal is not working. You are giving thyroxine too much. It will not be calling up on adrenal. Adrenal will not be calling up to rise to the occasion. So there will be adrenal crisis. So in such situations, we must, in the secondary hypothyroidism, replace the steroid first, then give L-prox, then give the euthyrox, then you give. So euthyrox has to be given only after steroid priming. I'll repeat again, euthyrox has to be given only after steroid priming, otherwise there will be adrenal crisis. Similarly, untreated pituitary insufficiency, you have to give steroid, other hormones first, then follow it up with euthyrox. Of course, in thyrotoxicosis, now it cannot be, this euthyrox should not be given if somebody has acute myocardial infarction or acute myocarditis or has got acute pancreatitis, because it will produce difficulty in such patients. Now, which are the conditions which require adjustments in thyroxine dose? Number one. Now, what are the conditions? Number one, if you have the intestinal malabsorption syndrome, like a celiac disease, like severe warming, we have a short bowel, all these situations, you have to adjust those quite frequently till the malabsorption improves. Common sense. Somebody who has got atrophic gastritis or has got H. pylori infection, which is rampant today, we have to treat the primary condition along with giving euthyrox, because that is very important. We have to take care of the H. pylori infection. If there is a fiber supplement like the bran, we have to give this drug with an altered time. I usually make it 12 hours. Altered time of high fiber supplement before you give the euthyrox. The drugs like aluminum hydroxide, the antacid, iron tablets, calcium carbonate, omeprazole, and also the other proton pump PPIs, they have interaction with this euthyrox, the thyroid hormone replacement. Therefore, you have to alter the time of the other this drug ingestion. In the same time, where you need to adjust the dose, conditions requiring adjustment of the replacement dose thyroxine for hypothyroidism, there is an increased need for T4 if there is a weight gain, and of course, pregnancy. I've got 4, 5, 6 slides. I'll show it to you. We have to give appropriate dose during pregnancy. There's a set value of TSH which has to be maintained. If there's an increased clearance of T4, like people taking phenytoin, this drug interacts with many drugs, but 3 important groups of drugs. One of the important group of drugs is the anti-epileptics. So like phenytoin, carbamazepine, the second drug is rifampicin. It has interaction. So they increase clearance of the thyroid hormone, euthyrox, the imatinib, and therefore we have to give increased dose, and some unknown mechanism like amiodarone, chloroquine, and no decreased need for T4 if the patient is losing weight, if has got androgen therapy, and in old age also we need to modify the dose on the lower side. So I have shown what has to be done if this thing happens. Now, coming to the most important part of the discussion today is about the hypothyroidism and pregnancy. Now, in the pregnancy, the definition of hypothyroidism is slightly altered. Now, in the setting of pregnancy, maternal hypothyroidism is redefined, I call it redefined, as a TSH concentration elevated beyond the upper limit of the pregnancy-specific reference range. So there's a pregnancy-specific reference range, which every country has given a guideline. In our country, it is between 2.5 to 3 and 3.5. We do not accept the ATS 4, we go up to 3.5. So it is 2.5 to 3.5 in the first, second, and third trimester. We have specific reference range for pregnancy. So any value of TSS above that is hypothyroidism during pregnancy. Now, primary overt maternal hypothyroidism, presence of a very elevated TSH and decreased serum FT4 and during gestation, and the both concentrations outside the reference range. I told you trimester specific reference range, so that is pregnancy hypothyroidism. Isolated hypothyroxidemia, we have normal TSH, but the FT4 concentration is low. It is low. The normal range of your lab, you can decide how much now, 4 to 8, 4 to 12. If it is low, this is isolated hypothyroxemia, and this is also a condition has to be corrected during pregnancy. Therefore, serum TSH measurements remains the principal determinant of maternal thyroid status. Very simple to do. You give the blood in the morning by 12:31 or 2 o'clock, the report is ready, and you can treat the patient very easily. It has to be done. The concept that Dr. Pathan was alluding to, that today we have a concept called fit to be mom. Fit to be mom. I mean, one of the very important aspects to examine a newly married couple who are going to eager to have child or going to raise a family is to measure the TSH level, because I call it a little effort will produce great results and change the destiny. Dear friends, now what are the guidance? It is from the guidance document for the screening and treatment of hypothyroidism in pregnancy. If one is residing in an area of known moderate to severe iodine deficiency, like in our place, it is the Himalayan goiter, the northeastern areas, we have to screen and treat. Obesity, pre-pregnancy and first trimester body mass index, if we don't take 30 today, we take it more than 27.5 to 28, we have to screen. History of prior thyroid dysfunction or prior thyroid surgery, symptoms of thyroid dysfunction, or if somebody has a goiter, history of thyroid dysfunction in the first degree relatives, like parents, siblings, first relative or children, history of diagnosed mental retardation in the family, in any member, we have to screen. Known case of autoimmune disease as I described, type 1 diabetes, SLE or rheumatoid arthritis, celiac disease, history of recurrent miscarriages. Somebody has got bad obstetric history, Professor Chaudhary will tell volumes about it, has got a preterm delivery, has an intrauterine demise, as a post-eclampsia, abruptio placentae, we recommend it has to be done. History of infertility, inability to conceive up to 1 year of unprotected sexual activity, intercourse, it has to be estimated. And somebody who is using amiodarone, very commonly prescribed today, of course, lithium, lithicar, recent administration of the contrast containing iodine. So the screening is mandatory. If not mandatory, these are the issues that one must take care of. Dear friends, TSH is lower, particularly the first trimester, and in the first trimester, please remember that FT4 is unreliable. Even though we say that the pregnancy has highest TBG, it double the value of normal thyroid binding globulin and also TBPA. We say that FT4, even FT4, which is not bound, which is free FT4, is unreliable in the first trimester. So we rely on the TSH, and it is usually lower. And as depicted, you will see how it correlates. And with the mix of gestation, you will find that how the TPG goes high, TSH, how it comes down and again goes up, and FT4. Again, to make a long story short, I must tell you that we have predefined the trimester-specific values, which must be strictly adhered to. How does pregnancy affect hypothyroidism? Maternal thyroid gland needs to produce more thyroid hormone during pregnancy. If it triggers progression to hypothyroidism in women with autoimmune thyroiditis. Since the thyroid gland needs to produce more thyroid hormone, but it do not supplement, it progression to hypothyroidism in women with autoimmune thyroiditis. And there is hypothyroidism, which gets previously was clinical, was manifest for the mothers who had earlier subclinical hypothyroidism. Now, what can hypothyroidism produce in pregnancy? Number one, miscarriage, and intrauterine death. It can produce hypertension or sometimes peaks during pregnancy, the eclampsia features. It can produce low birth weight baby. It can produce preterm baby. It can produce respiratory distress syndrome RDS and consequent hospitalization, and possibly a birth defect or most dreaded low IQ baby. It can produce excessive bleeding during delivery, and it can produce, as I told you, miscarriage and IUD. Therefore, my dear friends, during pregnancy, the screening for the TSH is mandatory, and we have to replenish depending upon a guideline. Therefore, adequate treatment with thyroxine, with subsequent restoration of the normal thyroid function, greatly reduces the frequency of such complications. So, before becoming mother, if possible, if not possible in our countries because of the various things I mean, at least at the beginning, thyroid hormone estimation is mandatory. Now, what are the national guidelines for screening hypothyroidism during pregnancy? Number one, uh, treatment of hypothyroidism in pregnancy and postpartum based on the serum TSH. This is from the national guideline of India, which we prepared in 2014. It is due for a revision right now. Now, number one, less than 2.5. I'm sorry. Yes, less than 2.5 in the first trimester. In the second and third trimester, I told you 3. And it is very important to do that, and then it does not need any treatment. If it is less than 2.5, and it is less than 3 in the first and the second and third trimester, it is normal. If it is between 2.5 and 10 in the first trimester, or 3 to 10 in the first, second, or third trimester, we have to give levothyroxine. We recommend 25 microgram per day during pregnancy, and post-pregnancy we don't need treatment. No treatment required postpartum. If scenario 3, patient has got more than 10 TSH first trimester, or for any trimester, we give at least 50 microgram of levothyroxine per day, and same dose we continue postpartum and keep on evaluating for at least couple of years. So if it is more than 10, we give 50, 2.5 to 10, we give 25, below 2.5 and 3, we don't have to treat. Pregnant women on treatment for hypothyroidism before they become pregnant is a known hypothyroid marching through pregnancy. Now, L-thyroxine dose has to be modified according to the specific range in the pregnancy, and the dose usually has to be upwardly revised. Pre-pregnancy dose, whatever dose you have stabilized, to be continued during postpartum. Now we repeat TSH 6 weeks postpartum. We follow it off for 2 years to decide whether the treatment is required or not. This is our national guideline, and we have kept it in every endo, every diabeto, and every gynec obstetric clinic, and whoever has fit to mom charts, we have put it there, and this worked out very well. Dear friends, there is a 2017 ATA guideline, American Thyroid Association guideline for the diagnosis and management of thyroid disease during pregnancy and the postpartum, and this has said in the high-risk women, check TSH as soon as pregnancy confirmed. We must do TPO antibody if the TSH is between 2.5 to 10, because that's the borderline range, and TPO antibody more than 50 in my lab. Each lab has cut off. One has to know that then it has to be treated. TSH below 2.5th percentile or 0.1 ml. See the thyrotoxic section. Now, in various grades, they have given the values. In our Indian guideline, we have modified it. But you see, the treatment depends upon the TSH level. Treatment with levothyroxine, and the dose varies depending on the values that we have. Now, this is the question which was asked by Professor Khan. Should women with subclinical hypo, I told you, that they have raised TSH level. I mean, you can take the cutoff value, depends. I take it up to 15, but people take it up to 12 and 13, but a normal T4 value, and here you find that the pregnant women with TSH concentration more than 2.5 should be evaluated for the TPO autoantibody. If levothyroxine therapy is recommended for these women, if the patient has a TSH more than the specific, I'll give an example. The specific that time is 2.5. If somebody has say TSH 10 and the TPO antibody is positive, we have to give the treatment. Even if TPO antibody is negative, if women has a TSH value more than 10, we have to give it. Levothyroxine therapy is to be considered in the TPO antibody positive women with TSH concentration more than 2.5, and even if it is below the upper limit of the pregnant specific specific range, we give treatment. And for the TPO antibody negative women with TSH concentration more than the pregnancy specific range, but below 10, we recommend treatment levothyroxine. We do not recommend levothyroxine for the people who are TPO antibody negative and those who have TSH in the trimester specific range. I'll make it very simple. If the TPO antibody is positive and the TSH concentration is higher than 2.5, it has to be given. If the TPO antibody is positive and the TSH above the pregnant specific range, it has to be given. So TPO antibody plays an important role. I will just describe few other challenges that we have. Number one is over-treatment. Sometimes patient gets over-treatment because of to lose weight, to become smarter, to appear very smart. People take over-treatment with levothyroxine. It occurs in patients who take more thyroid hormone than is required. It occurs in 1/5 of the cases. And what exactly occurs? Two maladies. Number one, the bones become weak, osteoporosis. The greatest danger is not auricular fibrillation. The greatest danger, the bones become weak, especially in the population like the postmenopausal women, like the elderly men who are more prone to osteoporosis and heart disease. It becomes a big problem. Therefore, we target a TSH level in the mid-normal range. We target between 0.5 to 2.5, 1.5, 1.25, up to 2. We don't target the TSH level should be higher than that to avoid over-treatment of the complications. Now, there are some people who get a combination of T4 and T3 treatment. Now, the levothyroxine is bioequivalent to T3 in the body. Not recommended as the primary agent, I told you, except in cases of thyroid suppression requiring quick reversal. I'll give an example. In the myxedema coma, we need T3 for a quick reversal, not otherwise. Its half-life is only 18 hours in contradistinction to 7 days of the levothyroxine. This short half-life makes it difficult to monitor, and the ATA-AAC joint guideline indicate there's inadequate evidence. I'll repeat again, both the ATA and ACE guideline have said there's inadequate evidence to support the use of levothyroxine and iodothyronine TPO3 in combinations. Now, patients who request treatment for hypothyroid symptoms in the absence of laboratory evidence of hypothyroidism, there are some people who want tests are normal, they want to be treated. Although hypothyroid symptoms are common, vague and non-specific, and pinpointing the precise etiology may be difficult. And there is no benefit in treating patients for hypothyroidism when thyroid test results are normal. I don't treat. People ask for treatment, we don't treat. In fact, treatment may be harmful if you're giving a person because of a little feeling under the weather. The reports are normal and there is substantial risk of subclinical or even overt hypothyroidism. Now, when do you need the changes in the dose? Now, the doses might change in a given patient over time. Observable issues, as I described earlier, pregnancy and postpartum, the dose has to be revised to maintain the trimester specific range. addition or discontinuation of other medications, like somebody has got the other type of anti-epileptic drugs than the one we do not give because of the neurological defect. Increasing age or weight loss may require not increasing but decreasing the dose. Increasing age and weight loss, and you have to evaluate the thyroid function test in 4 to 8 weeks. Now, some people have persistently elevated TSH level despite thyroid hormone replacement. Now, tissue level on responsiveness to thyroid hormone is rare and is caused by mutation in the gene that controls a receptor of the T3, rendering it unable to bind with the hormone. Now, this is a very rare condition where we have a genetic defect where there's a receptor for T3 which is unable to bind with the hormone. So far, only 300 families have been identified genetic mutation, and such patients will have adequate level of thyroid hormone that are ineffective, leading to persistent elevation of TSH and will continue to have symptoms. We have to give them symptomatic treatment. It's very rare. Only 300 families in the whole world today. Now, coming to the people who have a cardiac disease, is there a need for documenting thyroid hormone replacement for a person with cardiac disease? If the person is more than 50 years of age or at the risk of cardiac disease, if you have to give thyroid replacement, start levothyroxine or a very low dose, 0.025 to 0.05 milligram per day. If there is no need, if we don't have to give, and the patient does not have the risk of cardiac disease, we can give 0.075 per day. TSS level, if the primary hypothyroidism, or pre-T4 level, if secondary hypothyroidism, to monitor every 6 to 8 weeks, and the dose of levothyroxine unit has to be modified. So what does it mean? It means that start very low if the patient has the risk of cardiac disease and above 50 years of age, and the patient has no symptom, you can be a little more bold, you can give 0.075. If the patient has the symptoms, yes, then you give much lower, 0.025 to 0.05. And if the person does not improve and still has lethargy, still has memory problem, consider adding at this stage triiodothyronate, 0.01 to 5 milligram per day. And if the patient does not have the lethargy or memory problem, you continue the treatment but monitor TSH and T4 levels annually. Dear friends, 2-3 scenarios before I finish. Obese patients, from a clinical perspective, obesity and mild thyroid failure are common disease and frequently coexist. One of our studies showed that among the obese, 1/3 at overt and 11% at covert subclinical hypothyroidism, almost 44 to 50%. It showed that obesity was more common in the overt hypothyroidism. In fact, subclinical hypothyroidism, half of them had obesity. Clinicians study particularly a lot to the possibility of thyroid dysfunction in obese patients. So Dr. Pathan described about type 2 diabetes. I'll come in the next slide. But obesity also, one has to be careful to keep the high index of suspicion of thyroid dysfunction. The problem lies in identifying obese patients who are affected by mild thyroid hormone deficiency, and little bit of hormone replacement does magic. On one hand, raised TSH may be just a functional consequence of obesity. On the other hand, thyroid failures, especially subclinical, may go undiagnosed in the obese patients. Therefore, I do the test more than once and try to find out. There is at most a modest effect of levothyroxine treatment in overt hypothyroidism in inducing weight loss. Weight loss does better. Benefit in subclinical hypothyroidism is not established, with no data supporting thyroid hormone use in the youth thyroid obese patients. So many people use in obese patients or youth thyroid or even subclinical hypo. Forget subclinical hypo. In the youth thyroid obese patients, people use thyroxine hormone, levothyroxine, there is no data to say that it is going to be useful. Elderly frail patients, increasing age declines thyroid hormone binding and serum albumin levels. The glucose requirement has to be reduced. I reduced by 1/3, at least by 1/4. The dose has to be reduced in elderly and in frailty. Number two, subclinical hypo is very common in this group of patients, of elderly frail patients, with almost 25% prevalence, and that increases with age. There are 3 population-based studies, not in India, but all the world over, where this is subclinical hypothyroidism is more prevalent in these people, almost 25% in this group. Now, certain clinical manifestations get more accentuated in elderly, like cardiac manifestation, auricular fibrillation, or silent heart failure, and the mood changes, mental changes. Overt hypothyroidism may precipitate congestive heart failure and present a pseudo dementia in this age range. So one India, I mean, we have today in India, Bangladesh, old age home concept, the care center concept coming up. One has to be allowed to this particular variety of elderly frail patients with subclinical hypo, having cardiac issues and having mental issues, mood issues. For these reasons, an elderly patient who is present with findings such as hypothyroidism or deterioration of the cardiac status, mental function, should undergo testing for the hypothyroidism. We start levothyroxine, a very low dose, 12.5 to 25, and gradually build up. Dear friends, patient on thyroid treatment and those who are taking oral contraceptive pills is a big issue, and I have brought this article from the BMJ Open in the birth control pills and risk of hypothyroidism study in the NHS, and you find that what it showed that using a large cohort of US population, the NHS study, US population, to examine the association between the history of taking birth control pills and hypothyroidism. The longer history of taking birth control pills was strongly associated with hypothyroidism. You know, the birth control pills are taken for a very long time from the very early age when necessary. So taking for more than 10 years, it was found to be associated with hypothyroidism. Do not forget the cause of nephrotic syndrome as a cause of increased requirement of levothyroxine replacement therapy. This is a very important paper which shows in nephrotic syndrome, there is an increased requirement of the thyroxine hormone. You may have to increase it. Now, if somebody is taking amiodarone, it has effect on the thyroid hormone profile, especially in the euthyroid subject. So, an iodine-rich drug widely used for the management of the arrhythmias like atrial and ventricular arrhythmias. It has potential effect on the cornea like corneal opacity, lungs, fibrosis, liver, a benzopyrenic derivative with a structural similarity to T3. It can produce both hypo and hyperthyroidism. So therefore, effect of amiodarone on thyroid hormone profile in euthyroid subjects. Now, if the duration of treatment is more than is less than 3 months, it can produce 50% rise in the T4 and T3. It can produce more than 3 months. It can produce more than 40% rise in the level of the hormone. So the long story, to make it brief, is that one on amiodarone therapy, one has to monitor. Now, one has to also monitor the thyroid function on a patient who has amiodarone therapy. It is essential to evaluate patients before and during amiodarone therapy. We all do that. It is ideal to monitor thyroid function every 3 to 6 months. We do free T3, free T4, and most important is the TSH. Dear friends, I have come to the end of my talk. I'll summarize by saying that treatment of adult hypothyroidism is the simplest truth and the greatest truth, and it has to be done. We have to index high, you have to maintain high index of suspicion. Do screening. I personally believe that do screening. Every type 2 diabetes comes to patient. I did not touch upon it because Dr. Farooq had already shown about type 2 diabetes. You know, those who require treatment with L-thyroxine are large number of people. So you have to do screening and you have to replace with levothyroxine. Caution needs to be excised if the patient is elderly, if the age is more than 60 years, in people with comorbidities like ischemic heart disease and hypocortisolism, because hypocortisolism, one has to give steroid first, then one has to give levothyroxine. In the elderly patients, those are suspected to have ischemic heart disease, therapy should be initiated at a very low dose, 12.5 to 25 microgram, and increase slowly at every 4-week interval. In patients with coexistent hypocortisolism, glucocorticoid replacement should start first, like we do in the pituitary failure, Sheehan's disease, then give the thyroxine replacement. Non-compliance, conditions which interfere with the absorption and metabolism of thyroxine or change in drug clearance, we have to change the dose. Adequate treatment with thyroxine during pregnancy with hypothyroidism, with subsequent restoration of the normal thyroid function, cannot be overemphasized and greatly reduces the frequency of complications. The dose of levothyroxine must be increased in patients who when they develop, those somebody on levothyroxine developing nephrotic syndrome, the dose of levothyroxine has to be raised. Clinicians should be particularly alert to the possibility of thyroid dysfunction in obese patients, as 33 plus 11, 44% people in obesity have thyroid dysfunction and they do benefit from levothyroxine. Longer history of taking birth control pills, one has to be also alert that is strongly associated with hypothyroidism, especially if taken for more than 10 years. Dear friends, I thank you very much for a very patient hearing, and we can have some discussion.
Thank you, Dr. Das, for the nice presentation.
Yeah, I'll just tell one thing that, this particular drug has been there for many years. You see that, it started with 1894, then it came to 1896. It has been there. So it's an age-old drug, and you can see its history is replete with a long-standing in the profession and for the patients and for the physicians. Now, it is used heavily in the 113 countries and in many patients, and one of the brands which is globally very important. And what is important is that they have a 95 to 105% potency requirement. I have given here. There is 95 to 105% potency requirement and this specification, and this drug beats that. So it takes care of the requirement to be potent, quality driven, and universally available. Thank you very much. Over to Professor Farooq and for the others for questioning and for the panel discussion.
Thank you, Professor Kedas, for elaborate discussion about the total hypothyroidism, particularly the when to screen, how to screen, how you can make a diagnosis, how you start the treatment, and what are the points you have to remember while advise the patient to take the drugs, particularly the absorption and the things is there, how to increase the dose and how the dose. And particularly the most important emphasis given by you about the hypothyroidism in pregnancy, very much important for us. Also, teacher is there, he will enlighten us about it. And the other conditions, particularly elderly patient is nephrotic syndrome, patient is congenital hypothyroidism. Every aspect you have now discussed and touched. I think so. We all participants and very much delighted and we get benefited from that. So that the knowledge can be induced from your brilliant presentation here. And now the floor is open for the question. If anybody in the chat box, I think I did not find any question.
We can listen to Professor Abdullah and Dr.
I think so. If there is a question is there, we can listen to Professor Abdullah.
And
Professor
Dr.
Abdullah, please. And
What's
your
the
experience and what you can say something about the thyroid management and thyroid dysfunction. What you have experienced in clinical practice.
Thank you very much, actually, for inviting me for such a beautiful occasion. Actually, I'm delighted and I'm also grateful to my foundation for inviting me in such a beautiful occasion. Already I have with me, already you know everybody. Professor Farooq, Professor Kedas, also honorable teacher also. Professor Kedas sir is here. Many audience are also looking. Thanks everybody. Whatever we tell, thyroid disorder, once it is a clear-cut case, overt case, clear-cut, from our student life, we came to know thyroid disease can be diagnosed by looking at the face of the patient. Whether it is hyper or hypo, just by looking you can diagnose. Even a hypo, it can be diagnosed by talking about telephones. There is one book, probably you know it, physiology. There is one line. This is the disease which can be diagnosed. Clear cut, I'm telling. Clear diagnosed by talking over telephone. At that time, there is aphorism still there. Anyway, in a clear cut, diagnosis is not a tough thing. In other cases,
It just spotters, sir. At least it just
Yes.
spotters when it is over. But what is more
yes, in an
important,
overt case,
how
now
to
that
treat.
I'm telling. In an overt case, that is not a tough thing. In other case, high degree of suspicion is essential. That is the real thing. And it can be missed by anyone because thyroid, any patient, not necessarily that he'll go to the specialist. They'll most to the go to the GP, internal medicine, even gynecologist, other institute, not necessarily endocrinologist. Maybe they will get case from referred from them. That is one. But high degree of suspicion is essential, no doubt, in every case of it, whether it's congenital, whether it's acquired, whatever it is. But suspicion is very, very important because most symptoms are non-specific, especially in early stage, in pregnancy, total nephrotic syndrome, and any other hypothyroid syndrome. That is true, there is no doubt. So suspicion is very, very important. Every physician, every doctor, everybody talk with the patient, take the history properly, examine the patient properly. Many diagnosis is possible. Automatic should be confirmed by investigation, not or TSA, safety for okay. But suspicion is essential. Until unless you suspect, you will not investigate also. And then there is every chance of missing. And there may be, if miss not treated properly, there is a chance of complication may happen. In some case, clear-cut case diagnosis, investigation also, even a single investigation TSA is sufficient for diagnosis. If you want to do T4, it's enough. These two are the vital investigation almost in every case. And if you examine the patient thoroughly, it is goitrous or non-goitrous. If goitrous tests are limited also, maybe in Hashimoto's, even in grapes also, it may be goitrous, either hypo, E followed by hyper, E followed by hypo. So grapes also is the important cause of hypo may happen. Definitely, if there is goiter, so the cause are different. Non-goiters, most will get to non-goiters also. So that is also not, I think, very tough, can be diagnosed easily by any clinician, by internist. If he takes the history properly and examines the case properly, it's not an easy thing. It is not a tough thing. Another, so every physician must be careful before in diagnosis, especially during pregnancy, especially in elderly person. Once it is diagnosed, must take to exclude any cardiac problem, at least take an ECG, take an echo, if any, sometimes organ, there may not be an issue, but there may be ischemic heart disease also, 60, 70 years, hypothyroid diagnosed. Before starting treatment, at least take an ECG, take the history, take echo, to exclude any ischemic, because once you start treatment, there may be, yes.
Abdullah, there is a question in the box they have asked. Very interesting question. If a pregnant lady has TSH below 2, we are saying up to 2.2 to 3 to
Yes,
maintain.
yes.
What does it indicate? Very intelligent question. You know, we encounter it sometimes during the first trimester. You know what happens first trimester? The SCG, the human chorionic gonadotropin is high. Therefore, the TSH hormone is high. Therefore, the value is sometimes TSH value is less than 2 in the first trimester. At that time, we do T4, T3, FT4, FT3 estimation. We don't do anything. But that settles down by the second and third trimester. So the questionnaire by Aminul Islam is that if it is below 2, don't bother. If it continues, it's a feature of hyper. But usually the first trimester below 2 can occur because of the SCG induced little rise in the thyroid level and subsequent low. What Sir has mentioned is very important, Abdullah sir, that in the elderly female, one has to be very alert to this point of first trimester lowering of the TSH below 2.5. Please continue, sir.
So that I'm telling us one more. What I mean in general, rare things rarely occurs, but you must think common thing commonly occurs. That is the thing. So if you want to say rare, that is not a question. That may think, but once you consider this, it is not difficult
Absolutely.
to diagnose. But one I'm meaning in any elderly, 60, 70 years, no history, but you have diagnosed hypo, I should, with my opinion, must do or must exclude ischemic heart, because once you start thyroxine, there may be subclinical or no asymptomatic, there may be overt symptom. That I'm meaning actually. So these are the important points. Pregnancy already you told, because it should be screening other already you have told nicely. Dr. Pathan also told nicely already. You have mentioned in details. I have little to help, little fat, nothing at almost, because everything you told. And
But
also,
I think
told
the point that you made, point Professor Pathan made, and the point I'm sure Dr. Chaudhary is going to make is to, sir, absolutely I'm passionate to say that at the earliest opportunity of somebody having hair fall, somebody feeling under the weather, somebody is gaining weight, somebody is not feeling fit, the screening, as you rightly pointed out, sir, today's world demands that we should screen people when we suspect minimally, because that will change the destiny. That will give them
no,
a direction.
this is all right. I agree with what I told. High degree of suspicion is any symptom like this.
Yeah.
All are not specific, but maybe hypothyroid as a differential diagnosis. Gaining it not necessarily hypo, but it is a differential diagnosis.
Absolutely.
So once you suspect, once you take the history, that I'm meaning, if a doctor, a physician, whatever, if it takes the history properly, it can be diagnosed. I think if you suspect high index of suspicion, that I'm emphasizing, must be the first earliest way to diagnose hypothyroid. That I'm meaning. Another, you told very nicely. Sometimes I have seen cases also. It is not uncommon, but not so common. Adrenal lymphocytes, I have seen cases. Patient started thyroxine without giving steroid, and the patient was in coma. I've seen adrenal crisis in my life also. Few cases. But that is important. Once a physician or once you start any patient, thyroxine must take the history. If you feel hypopituitary or adrenal insufficiency or cortisol, or if you suspect, you do the things, and at the same time you can investigate cortisol, ACT, whatever it is. According to your history and judgment, it can be taken. There is also for pregnancy or due to. Another thing, I've seen also few cases in my life, unexplained heart failure, especially in elderly, must exclude also hypo. I've seen cases, heart failure, no hypertension, diabetes, no other dyslipidemia, nothing. But thyroid, I've seen cases, it was diagnosed as because of hypothyroid. So that repeatedly I'm telling, high degree of suspicion is essential. So I've seen unexplained CCA for heart failure. Also keep in mind, hypothyroid may be one cause, nephrotic syndrome, because in a case of nephrotic syndrome, chance of missing in any case. So it is, once diagnosis is confirmed, nothing is that
Assalamualaikum.
Interacting of that. Keep in mind also. These are not common, but also not rare. But once again, suspicion is very essential. So after this, almost every day, almost we are getting many cases who are missing also, diagnosed later. Late diagnosis may be dangerous, especially in pregnancy. It is important because it is not only for mother, but the baby also. So I don't like to add more. I'm very happy because I have learned many things from Professor Pathan, also Professor Akedas. You told details, many things. So I thank you very much again for your nice presentation, both of you. Also, I'm again grateful to my foundation for arranging such a beautiful discussion. And levothyroxine already told is an old drug, no doubt, by Mark Farnabas. We have now many companies, they are preparing. But whatever they are preparing and giving to us, many companies, they are drug companies, they are coming to us, we are writing also. Quality is difficult to say which one is best one, better one, difficult to say. But levothyroxine definitely by Mark is the oldest drug prepared by them, manufactured by them. Hopefully, they are probably going to marketing in this country. We'll see this. We definitely will use. Sometimes I use my patient also will see. If I find it's quite effective, good, definitely we'll see. We want a good drug, no doubt. Thank you again very much
Yes, sir.
for this
Thank you, sir.
presentation also.
Thank you, Professor Abdullah. In the beginning, I highlighted us about the different aspect of your own experience in your life about the management and diagnosis of hypothyroidism. We have with us our great teacher, the renowned teacher, respectful teacher, Jose. Teacher is vast knowledge and last long experience about the diabetes, the hypothyroidism in pregnancy. Sir, could you comment and we will sorry you will
Our regards to you, sir.
knowledge about it. Sir,
Well,
sir.
thank you very much for inviting me.
बांग्लादेश के रास्ते
First of all, I must
plus
confess that I was at a disadvantage because the voice that was coming out through my computer was not really very clear. So maybe this computer also had some hypothyroidism. I do not know.
No, sir. Probably somebody had opened the microphone. Please do the microphone.
Tried many ways, but it didn't improve. Particularly, I lost many of your comments. But in any case, I'll make some general comment.
Yes.
Now, the first of all, I think thyroid disorder is such a subtle type of disorder that it produces its damage without much announcement, much symptom. And this we find very often because we deal with women during or outside pregnancy. And as you all know that women are much more vulnerable to a thyroid disorder, particularly hypothyroidism. Problem is that it is common in pregnancy. In our country, I think it is maybe around 10%, but the symptoms are so mild that it is often missed. And sometimes it is confused with the symptom of pregnancy itself. So hyperthyroidism is more likely to produce the symptom that we get in pregnancy, like tachycardia, feeling of weakness, rise of pressure, and everything. Hypothyroidism is more subtle. But in any case, I think there has been a failure on the part of the female specialist or obstetrician and gynecologist to emphasize the importance of euthyroid state in being well-being and also carrying their pregnancy successfully and without any harm. Nowadays, I remember my professor a long time ago when TSH estimation was not available, a long time back. He had a hunch that the patient who had this pregnancy sort of problems, not feeling well, constipation, lethargy, so on, he used to take a small amount of thyroid powder. Levothyroxine was not available at that time. It was thyroid, what is called thyroid sicca or something like dry thyroid powder. So from that time, we thought that thyroid must be an important component of the overall well-being of women, particularly during pregnancy. And lately, when lots of people are coming for the investigation of infertility, we have also found that this can be a predisposing cause. When I was in UK many years ago, they actually categorically told that TSH estimation was not necessary in the investigation of infertility because in UK at that time, less than 1% of infertile people were hypothyroid. But that situation is different here. We get more patients with hypothyroidism and the proportion is actually more. So problem is that in most cases up till now, we go on investigating the women after a pregnancy mishap has happened, or a repeated abortion has happened, or the patient is unable to conceive. But the concept of screening apparently normal women, particularly in case of preconception counseling, the estimation of thyroid function is not a norm up till now. I think that is one area where we are lacking. Symptom or no symptom, all patients should ideally have a thyroid screening before they go on trying for pregnancy. I think that is one thing. And if they have not done it before, they must do it.
Absolutely.
During pregnancy, first trimester, as per Dr. Ekadas said, it may be confusing because of a high level of HCG, but second and third trimester, it must be done, and appropriate resources must be given in order to get a good outcome, not to push the patient towards some sort of mishap. So I think this idea we have not been able to transmit even to our colleagues up till now. So pre-pregnancy counseling and screening for thyroid function is not still a routine. It is done only a small portion of the people who are contemplating pregnancy. But we are doing it more in those patients who had pregnancy-related mishap. Another area, as you have said, that the postmenopausal women, they are also a vulnerable group. And they are also not being regularly screened for this thyroid function. I think even then, so that is one area where we can interfere. Obesity is another one. And as you know, gestational diabetes is quite common in this country, Southeast Asia. And I think some of these people may have a higher risk of thyroid deficiency compared to the normal people carrying normal pregnancies. I think there are many areas where we still have to actually go on screening for thyroid disorder in order not only to improve the quality of the life, particularly of women, but also in order to protect them from pregnancy or non-pregnancy mishaps altogether. So thank you very much for this extensive and very illuminating discussion on thyroid function today, and particularly by Professor Farooq Pathan and Dr. A.K. Khan, and Professor Abdullah has given his very wise opinion. I think I can't add much on that, but I thank them again for bringing this into focus. And I think
Can I have one?
they make people more aware that thyroid deficiency is a real problem in this country, and it should be tackled in the proper way so that the quality of the life of people, particularly women, does not deteriorate because only of thyroid deficiency.
Sir, I
Thank
have
you
to
for
add
having
one thing.
this timely webinar.
Sir, with chairman's permission, sir, can I say, sir, Professor Chaudhary, sir, you are teacher of teachers, my teacher, and my pronouns to you, sir. I must tell you, sir, your answer is prophetic. We did a study which published, sir, Professor Pathan has seen this in the IJEM we published, sir. We did 11 cities in 9 states, sir. We studied the prevalence of hypothyroidism during pregnancy. It was exactly what you said, 10.9% to 13.3%. And you said prophetic answer, 13%. That is great. Number 2, sir, what you said is what Dr. Abdullah had started to say. Probably I interfered with him in his speech. Sir, the elderly women are more prone to hypothyroidism. Am I correct, Dr. Abdullah, sir? It is the worldwide elderly women.
Yes,
and
you
touched upon that issue. I would implore, sir, give me 1 minute time, sir. I would implore that elderly female, am I correct, Pathan, sir, my chairman, sir? It must be 3 times must be screened for hypothyroidism because we ignore them. We know many of the symptoms of aging, sir, are same as hypothyroidism. Am I correct? Therefore, unless you do a TSH with a FT4 level, you will miss them. And there the people will greatly benefit from their particular thing. And you beautifully said, and sir, one more issue in my country, sir, we give lot of vitamins, iron and vitamins, folic acid, iron, selenium, and whatnot. Only we tell them not to take at the same time because that reduces the levothyroxine dose. And we have been successful in the chart that we give to the obstetric OPD. We give them this. And last, you have touched upon a point, sir. I'm the president of DIPSI, Diabetes and Pregnancy Study Group in India, sir. I'm the past president. Today it is Sunil Gupta. We are grateful that you touched upon the issue that GDM people can have variety of thyroid disorders. So in GDM, one has to take special care to look for thyroid abnormalities because again, supplementation will give great results. Thank you, sir, for this prophetic talk. Over to Chairman, sir, for the
Thank you, sir, for elaborate discussion about your valuable opinion and rightly have a deep opinion about the screening of the women, particularly before pregnancy and older people, older women also, to improve the health. Thank you everybody. Thank you, Professor Abdullah, Professor Tejuddin sir, as a panelist. You have given the great opinion to us, and also Professor Kedas had nothing to say about his presentation, about his the remarks in all aspects of the thyroid disorder as a whole, and giving emphasis on the screening when you have great suspicion about the thyroid dysfunction, either in the newborn baby or the children or the reproductive age of the women, even the older age group, whatever may be, even the patient is suffering from cardiovascular disease or patient is having osteoporosis. In all aspects, it is important. So I think so. Great consensus required in this area between our countries, South Asian country, more or less the same. I hope Professor Das will take the initiative about make a consensus guideline about the thyroid disorder as a whole, not only pregnancy but
I promise I'll do it, sir. From
Okay,
the surface, from the South Asian Federation perspective, Mukul Dai is here. So we will do it. We'll do it. We'll do it in
It's a great idea, sir. It's a great idea. It's a great idea.
I think so. We have no self-consensus guideline. Suppose we have done the GDM declaration, we have done the prevention plan. I think so. This area, because I think so. More than diabetes, the thyroid disorder is more common.
Absolutely.
Underdiagnosed. Underdiagnosed. So thanks everybody. Thanks for Kedas again, my beloved teacher, beloved faculty.
My humble gratitude that you brought me here, sir. And I'm really delighted. You can see I'm delighted to be here. And evening is for me still young. Evening is very young for me, sir. But I realize that we have to close. But I must tell you that I'm excited. I'm inspired. We'll do this surface guideline on the hypothyroid. We'll do it quickly. We'll do it in a virtual mode. It does not cost anything. We'll have allotted chapters, presentation, and we'll publish it. And sir, I'm extremely happy, thankful to Mark and thankful to you, sir, for chairing this session and giving a masterly and scholarly two adjectives and for in the beginning. And thankful to Dr. Abdullah for the insightful talk, and of course, teacher of teachers, mentor of mentors, for his blessings and for his words of wisdom. I really enjoyed.
Thank you, Doctor. So we are at yeah. So we are at.
I can get to put the scientific part here. Probably the Mukul can take.
Yes, sir. Yes, sir. So thank you, doctors, all of you doctors. The dais is open. If anybody want to ask any question, we have eminent speakers with us. So like anybody can ask any question if at all it is there. Or you can get in touch with us. We will definitely try to get the reply from the eminent speakers also. So in the meanwhile, I'll take this opportunity to just wanted to launch Euthyrox officially. So it will be just 2 minutes video out there.
Hello. Good evening to everybody. So I have one question to our Professor D. Chaudhary sir. Sir, if one TSS level less than 0.5, sometimes coming the first trimester, what should we do at that time? Less than 0.5 or 0.4, sometimes we found like this TSH level. What should we do at that time?
Hello.
Hello.
I think Professor Chaudhary sir will be answering. I'll just tell from my side. The madam, very pertinent question. It occurs very rarely when it goes down below 0.5 to 0.4. And one has to keep in mind that it can be in the first trimester. Usually for the SCG, we correct. In the second trimester, but always we must give it E4 level. If it is extremely high compared to the first trimester, then we must consider hyperthyroidism. Dr. Chaudhary will give the answer. The teacher of teachers. That is not here. That is not here. So that is the answer, madam. If it is 0.5 and 0.4, then do a thyroid level. It is acceptable level. Just wait till it to be over. If it is very high level, keep the index of suspicion for the hyperthyroidism, because such a low thing with a very severely high FT4, one has to think of that. But usually they get corrected by the second end of second month, beginning of the third. We can get hyperthyroidism maybe here.
Okay, thank you so much.
Thank you, sir.
So in the last, we have Mr. PK Sharma with us, who is the director for emerging frontier markets. So closing remarks from Mr. DK Sharma.
Good evening, doctors. Thanks, Dr. Ekidas, for a very beautiful presentation and a lot of insights for all the doctors over here. Overall, thanks to all the doctors who have participated, and mainly to the panelists, Dr. Ekidas, Dr. Farooq, Dr. Chaudhary, and Dr. Abdullah, and all respected doctors who have attended this seminar. It's an honor for me to have the opportunity to give a vote of thanks on this special seminar which we had for the launch of Youth-A-Rocks. I, on the behalf of Merck, extend a hearty vote of thanks to all the delegates of the seminar for their presence and the contribution to make the symposium exemplary. Thank you all once again for the time taken out for the day, and it's quite late in the night also. Thanks for all of you. Thanks once again. Thanks all.
Thank you all. Thank you everybody.
So, doctors, we promise that we will definitely facilitate the SARC chapter to develop the guidelines. And Dr. Das and Dr. Farooq, you need to play a very important role in that.
We are in touch. But I will take the lead. I'll join, and I will initiate, sir, for this. Sanjay, tell Sanjay about it. Yes, sir. We have our own group, sir, own mafia. So we will in a lighter vein. So we'll do it, sir.
Thank you, doctors. Thank you for joining.
Thanks, Dr. Farooq.
Thank you, everybody. Thank you for, sir. Thank you profusely.